Pulmonary complications of illicit drugs and prescription medications. This is probably the most popular presentation I do, possibly competing with the difficult airway one. So we have quite a bit to cover here. So we're going to kind of run through this real quick. All right, hang on. All right, back. All right, no, I don't have any clinical affiliations at the moment because I'm tied up writing my master's thesis. I basically have a bunch of clinical experience in a bunch of different things. I helped edit the Oak's Pocket Guide. I'm cross-trained in cardiac ultrasound. I used to be a flight RT on an air ambulance. Used to be an EMS supervisor. I do a whole bunch of stuff in forensics that if you care about it, ask me later. So I'm doing a degree in forensics actually. So this presentation is going to contain some humor, some sarcasm, and some historical and pop culture references. So viewer discretion is, of course, advised or encouraged, depending on if you have a sense of humor or not. So what are we going to talk about? We're going to talk about the different substances that are associated with pulmonary complications. We're going to talk about how they have those effects and why they have those effects and how to watch out for those effects. And also, if something happens, what do we do about it? Obviously, with things like this, prevention, an ounce of prevention is worth a pound of cure, but you got to hurry up and, be able to deal with it if it does occur. So sources of complications, you have about 300 different medications or drugs that have been identified. This number keeps climbing, hence why the plus there. This number came from 2016. This number is probably increased by 10 or 15 since then. But it can do either a primary or a secondary pulmonary disease as a complication. So either it's something that directly goes after the lungs, or it causes like a system-wide problem that targets the lungs. So primary versus secondary. So unfortunately, or fortunately, depending on how much of a nerd you are, it means we only have time to get into a few examples in any real detail. And this is one of my favorite topics. So trust me, I can do this very easily. I promise not go overboard. 3 drinks later, nailing the 95 theses to the church door about pulmonary drug complications. I could easily do like a 4 or 5 hour talk on this subject if I really wanted to. So some sources of complications, antineoplastic agents, so your chemotherapy drugs. Bleomycin is the classic example, and we're going to spend probably more time on bleomycin than almost anything else in this talk, because it's kind of the classic example. Antiarrhythmics, amiodarone being the most common example among currently used drugs. Some of the older antiarrhythmics also had this effect, but that's one of the reasons they've fallen out of favor. So you also have illicit drugs and also what they've been cut with. Sometimes it's like the whole, it's not what the wind is blowing, it's what the wind is blowing. Or it's not that the wind is blowing, it's what the wind is blowing, excuse me. Ron White's going to yell at me for that one. I think I screwed it up. But basically, it's not necessarily the drug itself. It might be what they cut it with to make it have more volume so that what cocaine they have or what meth they have or whatever drug it is goes further when they're trying to sell it. And anti-tubercular medications, so like isoniazid, INH, can also cause this problem. INH is just a nasty medication all the way around. Antibiotics, nitrofurantoin, better known as the stuff that turns your pee bright orange when you have a urinary tract infection. It actually has some problems with respiratory problems as well. Antiparasitics, levamisole, which is actually a veterinary antiparasitic, and it's actually related to one of the things I talked about before, and I'll get to that in a minute. Your sulfa drugs, aspirin, antihypertensives, ACE inhibitors. It's not just angioedema. Beta blockers, immunosuppressants, immune modulating agents, anticonvulsants, phenytoin being the classic example there, antipsychotics, chlorpromazine being one, capitin, methyl-dopa, sulfasalazine, which is a sulfa drug, but it's actually used for rheumatoid arthritis nowadays. And so all these different drugs, all these, basically almost every category you can think of has some sort of pulmonary complication in some way, shape, or form. Now, the way it can accomplish this is very, very diverse, just like the medications themselves. You can have allergic reactions. It can trigger asthma. It can trigger eosinophilic pneumonia, which that's the top picture there, actually. That is what eosinophilic pneumonia looks like, or pneumonitis. looks like on a microscope slide. All those little purple dots are actually the nuclei of white blood cells, eosinophils in that case. Hypersensitivity pneumonitis, which we're going to talk about that in a little bit. And that's actually the condition that led to this presentation existing. I'll explain why here when we get to that. Inflammation of the bronchial mucosa with or without scarring, which that's what is the autopsy picture down at the bottom there. That is a lung that's been preserved in formalin and then sectioned. And you can see how normally the bronchial walls that far out in the lung are very, very thin. Those are scarred up and they shouldn't be all tortuous. They should be all curvy like that. That's right here. That shouldn't be curved like that. That should be nice and straight like this one. Or it should be nice and rounded and smooth. Like this is a normal one. This is an inflamed one. You can see the difference in the thickness versus this one. So that's what we're talking about when we say scarring. And this is what happens in ARDS as well. Things like that. And all the little dark deposits you see here, those are actually tar from smoking, going out to any of the smokers that are in the audience. I mean, it's a room full of RTs, but there's still RTs who smoke. Pulmonary edema, pleural effusion. This is actually an autopsy image of a stillborn baby, actually. There's a pleural effusion there because the lungs never expanded. Mediastinitis, which is just an inflammation of all the tissues in the center of the chest or surrounding the heart and the great vessels. Not somewhere you really want to have inflammation or irritation, because then it gets into the things there and it causes further problems. Also, it's just extremely uncomfortable, as I understand it. Pulmonary vasculitis, interstitial fibrosis, which is what that image shows there. All this here is scar tissue. It's disorganized, it's whitish colored. That's collagen and other proteins that have built up in between the alveoli here. Basically, interstitial just means in between something, like in between rooms, in between alveoli in this case. And then you can have cytotoxic effects upon pneumocytes, which you can have basically, you can end up with a surfactant deficiency if it goes after one type of the pneumocytes, whereas you can also have tissue breakdown if it goes after another. Alveolar hemorrhage, which is uncommon, a hemorrhagic pulmonary infarct, which is actually what that image is there. The alveolar hemorrhages are uncommon, they're not rare, but pulmonary infarcts are extremely rare because the fact that the lungs, the tissue themselves has its own blood supply in the form of the bronchial arteries. So if one's obstructed, like you have a pulmonary embolism, you're probably not going to get a pulmonary infarct unless both sides are blocked up. And then you can get into drug-induced autoimmune responses, such as drug-induced SLE, systemic lupus erythematosus. There's a $5 word for a condition that, was featured in 3/4 of the episodes of House. So, but yeah, usually when you have pulmonary infarcts, they're wedge shaped because of the way the blood flow in the lungs is structured. So that's why it looks like a little triangle of, the disgusting way this was described to me by a pathologist is if it looks like the jelly filling in one of those thumbprint cookies. And I'm like, thank you, doc. Thank you. You just ruined one of my favorite foods, one of my favorite desserts. Now, if he had to ruin it for me, I had to ruin it for you. So there we go. So drug-induced autoimmune responses, drug-induced lupus. So this is the obvious joke of Dr. House, as I said. Is this lupus? So that's a person that has a runny nose. They probably have hay fever, not lupus. But that seems to be the reaction. So infectious complications. On the left there is an atypical pneumonia, old pneumocystis carinii, pneumocystis jirovecii. Now, then the other one over there is just a very, very consolidated, scarred up lung. I forget exactly what that one is. I'd have to look at the original image to see what that one is, but that's just basically your standard caseated cheese-like fibrosis. It's like a very dense cheese is the way it's always described, versus caseating necrosis, which is something else. You'll see in a minute. So antineoplastics, your chemotherapy drugs. And of course, you go with the pop culture reference here is Archer and the season where he had breast cancer. And there was a thing about counterfeit chemotherapy drugs. And, there's like, right, yes, the cyclophosphamide, which is actually derived from one of the chemical warfare agents used during the First World War. Bleomycin, though, is the one we're probably going to spend most of the time talking about here because it's the major one. That and methotrexate are the two big ones that cause problems and are fairly widely used. Bleomycin is a very, very potent medication, and it tends to not be quite as selective as we'd like it to be. Methotrexate is used more widely. It's not just used for cancer; it's also used for rheumatoid arthritis and things like that. So it can have some really nasty side effects, in addition to all of the other stuff going on here. So these complications, their initial presentation can look like an upper respiratory tract infection or pneumonia. The patient will present with a fever, often a very rapid onset fever. And if you do a chest x-ray on them, it's going to have pulmonary infiltrates in about 1 out of 5. Even if you catch this early on, it has a high fatality rate. Unfortunately, it depends on who you talk to and what the exact fatality rate is. I've seen case fatality rates that are described as being as high as 60 to 75%. Some folks say 30%. It's just kind of one of those, depends on the population you're looking at. So, okay. Basically, if you have a patient who's on chemotherapy and they present with this, you have to have the hair up on the back of your neck saying, woo, 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 this might not be an infection. Let's not get too quick to just go down that path and not make sure it's anything else. Because it could be the drugs, not the bugs, basically. Now, some of these present with a cytotoxic effect. So basically what you get is it's called microangiopathic hemolytic anemia. Basically what happens is it goes up to the lining of the capillaries in the blood, in the lungs, and it causes them to become rough, basically, for lack of a better description. Basically the epithelial lining of the blood vessel basically becomes it's like the curbstones on a flagstone sidewalk come up and you stub your toe on it. Same thing with a blood vessel or a blood cell coming through. A red blood cell hits it and it'll rupture it, cause a hemolytic anemia, and it presents as you suddenly have all this released hemoglobin, and the body, when these epithelial cells are not lined up correctly, fluid leaks through, it carries the hemoglobin through, and they end up with a frothy pink tinged, sometimes actually frankly bloody pulmonary edema. Or you can have an eosinophilic pneumonitis, which I showed you earlier, granulomatous, depending which way you want to pronounce it, reactions which are scarring. You can also, like I said before, it can kill, alter, impair type 1 and type 2 pneumocytes, so you can have tissue destruction or loss of surfactant. And some of these, you'll have all of these at once or in rapid sequence. So it gets to be it can go from bad to worse to why did I come into work today? Very quickly with these patients. It's going to be, it's complicated, and trying to juggle it is often, and sort it all out. It's stuff like this. It's complications like this why oncologists are some of the most brilliant people you'll ever come across, because they have to know all of this stuff and a little bit about a whole lot of different things. It's like a critical care doc, but they also have to have the knowledge of all the cytotoxic things these chemicals can do. If you want to have a very detailed conversation about this, I suggest going and finding an oncologist who's also got a PhD. So when I do this in person, I usually give away a copy of the Oakes Pocket Guide, but I just leave this slide up here anyhow. If you've ever wondered what a bronchogenic carcinoma looks like, that's what it looks like, that white egg-shaped thing there. That is a bronchogenic carcinoma. And basically it is actually spread up into here, there. This is actually a blood clot. It's probably just thrombus from the patient having, it's not actually an embolism, but but yeah, you can see how it's there. There's some here. And then there's, if they're that pressure probably had it spread into their as well. But you can see it was, if this hadn't been cut, this would have been compressing right here. That's why patients who have, wastes grow. So other question, second question, and this is always the one for the students. It's okay, what is this? And I'll tell you it. It's not a drug complication, but it's going to be brought up later. If you've ever wondered what tuberculosis looks like in a lung, this is what it is. This is that rotten hamburger case-eating necrosis that you'll hear described. You ever want to see a pathologist jump back from a table at autopsy real fast? Open the chest cavity up and have a lung that looks like that. Yeah, everybody dives for N95 masks. I'm pretty sure we always wear them all the time now during autopsies, but yeah, there's that. So moving on. So, okay, granulomatous reactions tend to produce a reticulonodular pattern on chest x-rays. Basically, reticulare is the Latin word for fishnet, and nodule is nodule or lump. So reticulonodule is basically like if you took a bunch of pearls and strung them onto a fishnet. So this is what it looks like magnified tissue-wise. So when you have a chest x-ray, it's actually expanding that image out basically, and that's what you get, why you get that pattern that you see when you see a reticulonodular pattern. This is what's causing it. This is the underlying. These are all scar tissue. I'm not sure what the actual underlying pathology there was specifically, but this is what it would look like. These are all the alveoli, and you can see how they're compressed here in between, and there's fibrosis spreading. So, but that's what that looks like. So about 10% of bleomycin will get what's called fibrosing alveolitis, which is a very nasty form of pulmonary fibrosis, because instead of it being interstitial, it actually becomes, it's actually going after the walls of the alveoli themselves. And so it'll completely encircle alveoli and close them off and cause them to collapse. This is actually the main reason this medication isn't used more widely. As you can probably guess, if it causes this in 10% of people, you don't want to use it willy-nilly. This drug is actually good for a lot of things it's not used for because of the hazards associated with it. So it can also induce what's referred to now as organizing pneumonia, which my fellow dinosaurs in this presentation will recognize this as BOOP, bronchiolitis obliterans organizing pneumonia, which I've always said that is the, I always hated the fact that they got rid of that because it's one of my favorite acronyms in all of medicine. So how fast can this progress? This is a lung of a mouse on microscope slides. So normal on the left there, and then A, B, C, and D is 3 days, 6 days, 14 days, and 21 days. So you can see how fast this scars up. So, okay. So we're unclear. It's unclear, and there's exactly how it does this and why it does this. There's a bunch of different theories for it. Honestly, probably there's an example of all of these to some degree. Excuse me. Sorry. So basically, you can have oxidative damage. You can have deficiencies in the enzyme that deactivates this medication. Basically, like some people who don't produce alcohol dehydrogenase don't clear alcohol as fast. There's also people who don't clear bleomycin as fast or other medications as fast, which can make it build up in the system and produce a toxic response. Genetics, which is probably the deficiency there. Inflammatory cytokine releases, so cytokine storm, et cetera, et cetera, et cetera. There's like reams of journal articles on this subject if you're interested. Go on PubMed and type in, bleomycin and pulmonary fibrosis or pulmonary complications, and it'll bring up a bunch of research articles on it. Higher risk in older patients, renal insufficiency. This medication is excreted through the urine. If you're on multi-drug chemotherapy, so obviously if you're getting the crap kicked out of you by multiple chemotherapy drugs, you're more likely to get it. Concomitant radiation therapy, which carries its own risks of pulmonary damage. And smoking, as if you needed a reason to quit smoking, you know, being on chemo is pretty much a good one as well. So here's the big takeaway on this one. You can induce ARDS in bleomycin patients by giving them increased oxygen. You can actually make it worse. There is actually a perioperative protocol that was developed by the University of Virginia, and they will never let you forget it, about how to treat this using minimal O2 exposure and and actually limiting fluid replacement. It's basically, these are patients where you're going to want to have to go with a high, you're going to have to probably use either, you know, in non-invasive ventilation or tube them and try to turn the PEEP up to keep their O2 level, the FiO2 down while keeping their oxygen levels satisfactory. It's a very complicated thing. And this protocol is, last I looked at it was like 5 pages long. So, but it's really detailed and really helpful. So it's a very good resource there. So keep in mind, when I say high FiO2s, this is a relative term. Worsening of cases has been reported with an FiO of 33%. So, you know, just because they're on a nasal cannula doesn't mean you're not causing worse problems. So the problem is, since you can't experiment on this sort of thing to find out what exactly causes it, and it also seems to be, there's individual variation, we're not sure how widespread this sensitization is and how to predict who it's going to be worse in. So you just kind of have to play it by ear. So hypersensitivity pneumonitis is another complication this can have, but it's less common, but it's still possible. So this is what I said, this is the reason why this presentation exists. That there's a patient who is still alive, thankfully, who had this. And myself, several other very, very good RTs, several who are better than I am, and several very competent pulmonologists missed this diagnosis originally. And this presentation is kind of my way of atoning for that, because this kid nearly died because of it, because it looks like asthma. It really does. You got a patient who's coming in who's outpatient, who's getting this, having this problem. They go to a primary care doctor and they don't do a PFT or a chest x-ray. And they just get handed a bronchodilator, then a long-acting bronchodilator, then steroids, and then this and that and the other. It's not, you have to have a high suspicion here, because it's going to present coughing, chest tightness, dyspnea, leukocytosis, myalgia, fever. So it looks like somebody who's got a superimposed upper respiratory tract infection on top of asthma, or just asthma if you're not doing blood testing. If you do a BAL or a biopsy, they're going to be eosinophilic. Normally, there are variants of this that are not eosinophile driven. And even PFTs sometimes don't allow you to differentiate between this and asthma in the early stages of it. It's the chest x-ray tends to be the kicker, or a CT. So when the kid gets bad or the adult gets bad, they go in the hospital and a chest x-ray is done and someone's like, oh shit, pardon my French, how to identify the military trained RT. So if this progresses long-term, you end up with a fibrotic form. Basically, it's like almost like idiopathic pulmonary fibrosis, except it's not idiopathic. Progressive exertional dyspnea, fatigue, cough, often productive. It'll be like your standard, you know, thin to kind of moderately thick white, you know, sputum. Weight loss, basilar crackles, because you're having fibrotic changes, so you're having alveolar ups and then popping back open with a deep breath. Digital clubbing, and it progresses from initially what can look like a either a obstructive pattern in very mild cases, to a combined obstructive restrictive pattern, to an almost strictly restrictive pattern with a DLCO that starts plummeting as it progresses. So the chest x-rays are not always ideal. because they can be normal or they can change over time as the patient better or improves or worsens. And this is not only caused by drugs, it can be caused by things just environmentally. Organic materials, farmers are exposed to a lot of shredded plant materials and things like that are dried out that cause stuff like this. So what you'll have is you'll often have these little fine opacities on the lungs that are just scattered, and they tend to be like middle lobes because their side, whatever's causing it tends to accumulate there. One, if it's being carried by the blood, it's lodging there because that's where the blood enters. Or if it's airflow, it's hitting there and it's not making it further down. So airspace diseases, you can see ground glass opacities, patchy diffuse, resembles pulmonary edema, or you can see full-up consolidation as this, if it's during a flare or it's progressed into the fibrotic stage. And you'll develop what's called lace lung, which basically the lung looks like a tatted lace pattern because it's reticulated. It looks like a net has been pulled down over there. So late findings, you have an enlarged heart from cor pulmonale. Honeycombing from fibrosis is usually worse upper rather than lower. Ground glass appearance on CTs and parabronchial thickening, like I showed you in that lung from autopsy where it has the thickened walls around the bronchi. Can tell it's been a long day. So basically scar tissue, and this is all because the body's response to an irritation is just like a oyster's response to a grain of sand. It tries to produce a pearl to seal that irritation off. The lungs are trying to do the same thing, except it's counterproductive. And you can see how this has got this like fine, delicate, lacy pattern to it overlying all of the tissues here. And it's worse in the middle lobes here. So and then you've got parabronchial thickening going out along here. And, that's, not a case you want to have, not something you want to see. If you see something like this, they're just writing it off as, idiopathic. Point out it could be hypersensitivity. Someone speaking up is how we figured the kid out. And it wasn't me, by the way. I wish I could say it was me, but I was one of the people who just was like, no, it's not. And it come to find out it was something in the kid's house. So, but this is what it looks like on a CT scan. This is actually, I cropped it so that I can make the image bigger to show it more detail. But you can see how it's fish scales. It's got a fish scale pattern because of the way the lungs are segmented, and it tends to progress from one to the next, to the next, to the next, to the next. And it'll pattern out along where the blood vessels are at. So where the pulmonary hilum is right here, where the blood vessels come in right next to the bronchi. And you end up having it patterns out, and it tends to follow that way. If it's something that's being carried like a drug in the bloodstream, that's how it's going to spread. If it's inhaled, it's probably going to spread more centrally, and then it's going to work its way outward from there. It's basically a depositional pattern depending on where it starts at. So basically, how do you screen for this? If it's not a patient on bleomycin or something else we're going to discuss here in a minute, it's basically whether you have the clinical hair on the back of your neck going up and going, woo, 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 look at this, clinical suspicion. You have to be, you can't go chasing, the old expression hoofbeats. Hoofbeats, it's horses, not zebras. But, sometimes it is a zebra. And, that's one of the reasons why one of the chronic genetic diseases that's very underdiagnosed in people with Ehlers-Danlos syndrome is their emblem for it is actually a zebra, because people get misdiagnosed repeatedly before the doc finally figures it out. Although once you've seen an Ehlers-Danlos patient, you'll never mistake it for anything else in the common forms. But so basically, if you have a patient that's got this, send them for PFT with a DLCO. I mean, PFT is not going to hurt someone. Might irritate the pulmonary function tech, but hey, if you start sending too many people, but that's just job security. And we're here for our patients first and foremost. So basically what you want to do is, if the patient's going to be getting bleomycin or methotrexate or anything like that, recommend that they get a baseline PFT and a baseline DLCO. and do repeated, make sure that the doc knows to repeat this. Oncologists are going to know, but if you've got a patient who's, being seen by an oncologist that's not necessarily, the most aggressive, you might want to be a little more assertive, or talk to the docs who are treating them when they're admitted in-house, talk to the hospitals, talk to the pulmonary critical care doc, whatever. There's a debate going on back and forth. This keeps changing. It depends on where you're in Europe, Asia, the US, Canada, Mexico, what the recommended frequency is. Basically, it can range anywhere from every cycle, before and after every cycle of chemotherapy, to every 2 to 4 cycles. 2 to 4 is the most common recommendation I've seen. People want to get real aggressive and do it every single time. Can't say I fault them. There's no harm in that. Better safe than sorry. So if you have a hypersensitivity reaction, or you have basically any of these things, first thing you're going to do is stop doing what's causing the problem. It's kind of like hey doc, my arm hurts when I do this. Well, don't do that. If the patient's having respiratory complications from bleomycin, you're going to stop giving them bleomycin. Basically, as soon as you have symptoms, or there's a major alteration in these PFTs, or in the x-rays, or anything else, basically, if you have clinical suspicion to going on, I'm going to hold it off, discuss it with the docs, make sure everything gets taken care of. And if they have it once, they don't ever get this drug again. So then after you have ruled infection out, you give them glucocorticoids. Now, you have to make sure you rule out infection first, because if you give them glucocorticoids and they actually do have an infection, it's going to become a really, really ugly situation very quickly, probably. So moving on to methotrexate, MTX, as you'll see it sometimes abbreviated, even though they're increasingly wanting us not to abbreviate things. So this drug is used against a lot of things like Crohn's, MS, various cancers, psoriasis. My mother took this for her psoriasis for years. Basically what it does is it basically blocks the ability of a cell to uptake folate. So one of the B vitamins. Well, folic acid, just like in a pregnant woman, you have to have it for fetal development. You have to have it for cellular development. And how it does this is it's involved with DNA and RNA synthesis. So basically, you derail the ability to produce proteins and for cells to replicate by blocking that enzyme, or that factor, basically. So it gets really complicated. It's one of those flow charts. It's like the whole picture of a map, factors leading to the First World War. It's arrows just all over the place here. This drug has some anti-inflammatory properties. It's why they use it in things like, rheumatoid arthritis. Has immunomodulating properties as well, which is why it's used in like Crohn's and MS and all sorts of other things. It's actually a really good drug if it works for the patient, if the patient tolerates it. Some patients don't. And it's, depending on how you give it also can be a factor too. So usually this isn't something you're going to give them one dose and they're going to have pulmonary toxicity. It's usually several weeks or months or even a year down the line with a very low dose oral schedule, because it's something like it takes a while for it to take effect. So you don't want to slam huge doses of it unless you have to, which you can have it onset very rapidly if you're giving it intravenously, or if you're giving it intrathecally, which is a fancy way of saying epidural, basically, which is used that way for certain central nervous system conditions. I've never actually seen it done, but I've heard that it's done. So now you will have pulmonary complications in about 1 to 8%, rough 1 to 10% of patients that are taking this for rheumatoid arthritis and related conditions. So it's not as common of a problem as some things, but it still is a problem. Now you're complicating your risk factors, enhanced age, you have an existing rheumatoid effect on the pleura or lungs, If you're using other anti-rheumatic medications together, just like it's not necessarily 1 + 1 = 2. Sometimes it's 1 + 1 = 5 because of a synergistic effect. If you have a low blood albumin level, hypoalbuminemia, basically methotrexate binds to albumin in the bloodstream, and also in cells too. So basically what you have happen is there's more free circulating methotrexate to cause a problem, if that's the issue. So if you start patients on, if patients going to be started on this, you want to make sure they've been screened to make sure their albumin level's normal and that they're routinely screened for it as well. So if you have diabetes as well as another risk factor, no one's really sure why. Oh, as I said, albumin reduces the protein binding, which allows higher circulating levels of free methotrexate. Hyperinsulinemia also mucks with this. The metabolism of this, there's other things that happen here that they're not fully aware of, because even people who are not hyperinsulinemic can have problems with the metabolism of this. They think there's something else going on with diabetics causing that problem. People who are chronically hyperinsulinemic are going to be more prone to it, but there is other things at play. There's other things associated with diabetes that are not just the insulin issue of it. Okay, higher or more frequent doses. The old expression with toxicity of dose. The dose determines the poison. That anything, even water, in a sufficient dose is toxic. Pre-existing lung diseases, abnormal baseline PFTs. Obviously, if you have a problem already, there's a chance it's going to make it worse or superimpose it on something. Renal insufficiency as ascites, so fluid in the abdomen, which tends to be a pooling location for albumin, which therefore you basically are pooling methotrexate in the ascitic fluid. So when it's finally moved back into the blood vessel, even a higher level, possible genetic factors, some people may just be more predisposed to this. So you have three major kinds of reactions. A lot of these are just going to be the same here. So basically, you're going to have a hypersensitivity pneumonitis. This is the most common complication. And if you see hypersensitivity pneumonitis due to a medication, it's probably going to be due to methotrexate. Organizing pneumonias, pulmonary fibrosis. It's often very, very rapid and very, very progressive and very, very hard to stop in a lot of patients. Interstitial pneumonias and pulmonary edema, pleuritis, and pleural effusions. So basically, it starts attacking or causing the body to go after the pleura, which then starts producing fluid, which ends up producing a pleural effusion. Thankfully, that's rare, because the one time I've seen pleuritis in somebody from this, the lady goes, I know, it's one of those, I feel so bad, I'm afraid I'm going to die, but I hurt so bad, I'm more afraid that I won't. So with methotrexate, basically the same pattern, same treatment as anything else that causes it. Don't need to go back over that. Infectious complications. These are indirect complications. So you've got your pneumocystis jirovecii ARDS lung there on the left. That is a cytomegalovirus pneumonia on the bottom right. Up top is an aspergillosis. That is a fungus ball, as they're quaintly known, and a cavitating lesion in a lung. So at autopsy. So basically what this is it can knock down your immune system so much that you can't fight off things that you would normally fight back. You would normally fight off. Oh, hang on. No. Oh, sorry. Hang on. Give me 1 second here. Didn't mean to do that. Okay, here we go. So basically, the other thing this can do is it can your immune system also keeps your other parts of your immune system in check. So if you don't have if your immune system gets knocked down, one of the things that can happen is called a lymphoproliferative condition, such as lymphomas or non-Hodgkin's lymphoma, which is a B-cell lymphoma. Often, this will go away as soon as you pull the methotrexate back, because the body's normal check and balance system kicks back in and goes, nope, get back in there. So this can be a result of either reduced immune surveillance. So basically, you've got the basically the immune equivalent of a cop sitting there with a radar gun going, okay, there, good. And then suddenly too many, there's this whole group of B cells comes tearing past you, like, wait a minute, nope, something's wrong here. But if the cop's asleep, everybody sneaks past, that sort of thing. Or Epstein-Barr infections, because when you knock the immune system down, it can cause Epstein-Barr that's been latent in the system to go haywire, which can induce a number of problems. So the lung and or pleura is not the primary target in this. These lymphoproliferative states, less than a quarter of the patients will have it. But you can have basically the lymphoma goes after the lungs and cause problems in that regard. And it basically is going to be its own set of problems. And it's basically handled in just the same way you would handle it. Normally you pull the methotrexate, try to support the patient until the immune system comes back online, and then you might have to do something about the lymphoproliferative state. But that's a question for an oncologist, not for a respiratory therapist. So I'm going to put that one not in my wheelhouse. So immunosuppressants and immune modulating agents. So you can have direct effects that can cause problems. You can have autoimmune complications. You can have infection due to immunosuppression. You're taking it for post-organ transplant. It can cause a graft rejection. You can have these lymphoproliferative states, which can induce leukemia. It can monoclonal gammopathies, such as amyloidosis. In lymphomas, things like that. And of course, the famous, my other pop culture reference for this is anytime you screw with the immune system, there's a chance you're going to have a bad time, which is followed immediately by one of the quotes from one of the rheumatologists and immunologists I used to work with, who like to say the only thing more difficult than spelling the generic name of a rheumatoid arthritis medication is untangling all of its potential complications. And that is very true. These drugs are incredibly complicated. And they're also incredibly hard to spell for the most part. So basically, it can cause all the symptoms you saw previously with the various chemotherapy drugs and with methotrexate, and basically all those problems that can exist there, you can exist with the drugs you're taking for things like Crohn's disease and rheumatoid arthritis or ulcerative colitis or psoriasis, things like that. Anything that's going to mess with the immune system, it can be unpredictable how it's going to actually complicate things. So with cardiovascular medications, and what percentage of our patients that we deal with directly are on cardiovascular meds? Probably over what, half to two-thirds, three-quarters. So unless you're dealing with pediatric patients, almost exclusively. So amiodarone, classic one. About 6% of patients are going to get a fibrotic condition from this. It's one of the reasons they recommend PFT screenings for patients on this. You can have ACE inhibitors will induce a chronic cough in about 15% of patients. In some patients, this is actually the limiting factor of how compliant they are with the medication because of how bad the cough is. Hydralazine can cause drug-induced lupus. Procainamide, cardiac antiarrhythmic, can cause it. Quinidine, which is an even older antiarrhythmic. I can't remember the last time I saw a patient on quinidine. I can't remember the last time I saw procainamide used, actually. Both can cause SLE, among numerous other medications it can. So basically with illicit drugs, and by the way, we'll get to the discussion of lupus here in a little bit. So I'm not skipping it. I'm just putting it to the end because it's its own part of this discussion. So you have illicit drugs. Most often these problems are actually caused by what the drugs are cut with. Talc being the, as we all know from the Johnson & Johnson, lawsuit and the aggressive ambulance chasing lawyer ads that are now on TV, talc causes all sorts of problems when it gets in the body because the body can't get rid of it. Well, you don't want to snort it obviously, any more than you want to sprinkle it all over your nether regions, because if it gets into the lungs, it causes all sorts of problems. Get to that in a second. Levamisole is it's still used in, much of it's used in the US as a veterinary antiparasitic. I know it's used in Europe as one, but it's was withdrawn from the US. It was originally used, and it was originally used in people to treat certain parasitic infections like pinworms and things like that, if I remember correctly. But the problem was they realized it can cause either lupus, or more commonly, it just knocks out every one of your granulocytes, knocks your neutrophils down, and also causes a very nasty vascular inflammatory condition where you basically end up with almost like a bed sore without having to have pressure first. Basically, it goes after the small blood vessels on the surface of the skin, and it causes the spot to itch. And so the person just sits there and scratches away at it, and they end up with a hole because of a combination of a wound plus no blood flow. So, all right. So these are unusual pulmonary emboli. Not all pulmonary emboli they're not always fat, and they're not always blood. That's talc. The left image is under normal light. The right image is under polarized light. By the way, if you have a polarized light filter and want to see talc glow, that's how you do it. A regular flashlight and a polarized light filter, you will make talc sparkle. It's actually kind of pretty, unless it's in your lungs, which you can see all the fibrotic change here along that, and then around this pale pink. It's called intracellular matrix. It's basically collagen and fibrotic, other fibrous growth trying to produce a scar basically around this. And the problem is it thickens up the alveolar walls. So this is what's called the talc granuloma. People who shoot drugs IV, they crush pills up and try to dissolve them. Well, talc doesn't dissolve in water. So these wind up lodged. And if they subcutaneously pop them under the skin, it ends up with this. It's actually kind of pretty under polarized light. It's not pretty when you've got it under, when you actually have a problem under your skin. But I guess under the skin of your forearm is a heck of a lot better place than, say, your lung. So don't do drugs, kids. This is another example. This is actually the early inflammatory stage of this, because you can see all the white blood cells that have accumulated around this, trying to these pieces here, pieces here, pieces here, because talc is just basically a piece of rock, and you've got it stuck in your lung or in your skin or whatever. So antibiotics. So your nitrofurantoin, your sulfa drugs, isoniazid, which is not technically, strictly speaking, an antibiotic, but it's used for antitubercular medication. Minocycline, which is one of the tetracycline drugs. It's used sometimes for acne and other things as well. So nitrofurantoin is the most common cause. Usually presents it actually produces looks like a respiratory infection, cough, dyspnea, fever. You discontinue the nitrofurantoin, which you've been taking for, say, a urinary tract infection, and the patient gets better because they switch off of this antibiotic for another antibiotic. Bam, you've got the problem resolves itself. Doc pats himself on the back and thinks he's fixed the problem by treating the infection when it's actually just gotten rid of the cause. Now, if you keep giving nitrofurantoin chronically, it can cause pulmonary fibrosis and interstitial fibrotic pneumonitis. So the way to differentiate what's going on is discontinue the nitrofurantoin. So if you've got a patient that appears to have a low-grade UTI and you look at their Foley bag and it's bright orange, you might want to suggest to the doctor taking them off the nitrofurantoin and be like, hey, can we take that away and see if it fixes this problem? If it continues to the point of it being fibrotic or it doesn't resolve, you start giving corticosteroids, or you might start giving them anyhow if you're sure the patient doesn't have an infection. So basically, a lot of the problem is this presents with these are masquerading. These conditions are all mimics. So basically, you're going to have you have to kind of be a detective here, which is kind of the fun part of clinical practice, honestly, in my opinion. So aspirin, a lot of people overestimate how much of a problem it causes in asthmatics. It only causes a problem in about 5% of asthmatics. The bigger problem is that, especially among older folks, they think a little bit is good, a whole lot is better. And the difference between a therapeutic dose of aspirin and a toxic dose of aspirin is actually very narrow. It's honestly one of those drugs you kind of wonder why is it still over the counter, honestly, given how many people have complications from it. And how many things have salicylates, the compound family that aspirin belongs to in it. So Pepto-Bismol, oil of wintergreen, Aspercreme, Bengay, things like that all have, or various formulations of Bengay have it in there. And you can also absorb this up to your skin and it's going to behave just like that is. That's why an aspirin overdose is actually referred to as a salicylate overdose. Acetylsalicylic acid is the actual name for aspirin. Methyl salicylate is oil of wintergreen, things like that. So what'll happen is in higher doses, if you get somebody who's taking, multiple stacked doses of aspirin, you can actually end up with a non-cardiac pulmonary edema. And in very high doses, it can actually produce something that looks like sepsis. It's actually got the you basically have a fever, you have leukocytosis, mostly an increased bands issue, fever, systemic vascular resistance plummets. They can go into encephalopathy, ARDS, disseminated intravascular coagulation, renal failure. This is one of those things where the patient comes in and they're complaining about their ears ringing. That's the giveaway. One of the side effects of aspirin toxicity is it actually causes a buzzing or ringing tinnitus or tinnitus in the ears. And you'll have people that are, that's the giveaway. It's like, how much aspirin have you taken? How many other things are you taking that have aspirin or aspirin-related compounds in it? People don't realize. I mean, there's a big thing now about everything. It has acetaminophen, like the bottle of Excedrin I've got sitting here. It says contains acetaminophen. Always read the label. Anything that has aspirin or salicylates in it should carry a similar warning for this reason. So the problem is this can occur with chronic or acute overdoses. And overdose recognition is commonly delayed or it's completely missed. And sometimes it's even missed until the autopsy, assuming that one's done and they do the toxicology. Because it looks like septic shock or sepsis. So just because it walks like a duck and it quacks like a duck doesn't mean it's a duck. It might actually be aspirin poisoning. Some other things that can cause this, like I mentioned before, anticonvulsants like phenytoin can produce SLE. Chlorpromazine is an antipsychotic, can produce SLE. Methyldopa, sulfasalazine, which is a sulfa drug, but it's used for rheumatoid arthritis. Capitan, which is another medication that's used for treating various things. So we're going to get to the lupus part of this presentation, and it's not lupus. It's never lupus except when it is. So you've probably seen a lupus patient without realizing it, because that's why that's that running shtick basically on House. Is it's a disease that presents in weird ways. It doesn't always present in a normal way. You can either get what's called a malar or a discoid rash, butterfly shaped, where you get these plaques that look like a psoriasis lesion, except they're bigger and they don't get scaly. So I'm going to hurry along here because we're getting close to the end of this. Serositis, so basically inflammation of serosa surfaces and effusions, pleural effusions from this. Glomerulonephritis, this is what renal failure is what kills people with lupus, by the way. Cytopenias, so knock down your edema, leukopenia, thrombocytopenia. People start bleeding. People start having immune sensitive infections. Photodermatitis, sensitivity to light. Basically, they go out in sunlight, they get the RAS worsens. So you can have vasculitis anywhere, CNS, kidneys, skin, everything. Messes with serum complements, so it messes with your other parts of your immune system. You can get thrombotic complications in the arteries or veins. Arthralgias and myalgias, so joint and muscle pain. This is the butterfly rash that you'll see. Now, the problem is this looks a lot like the irritation from a CPAP mask, is what I've always tell people, a full face mask. The trick is that it'll actually go up sideways. It tends to follow the curve of the zygomatic bones up the cheeks instead of curving downward. And it has a distinctive look to it. Once you see it, you won't mistake it. But I always tell people it follows the pattern of where a CPAP mask would sit on a full face CPAP mask would sit. So you can have that. So drug-induced lupus usually happens after they've been on it at least 3 months. It can cause a bunch of different pulmonary issues, like all of these medications. and all of the secondary complications. So you can have pleural effusions, reactive airway disease, so it can cause that. Vasculitis, pulmonary emboli, which that's what a pulmonary embolism looks like at autopsy. Interstitial lung disease, pulmonary hypertension, infectious complications, diffuse alveolar hemorrhage, and then a very nasty thing called acute lupus pneumonitis, which is awful. Basically, it's just a massive lupus as the immune system is turned on the lungs and is going at them with everything it's got. So treatment is dependent on presentation. This disease is very heterogeneous. Pulmonary hypertension tends to be a better prognosis than other causes. If you get the lupus knocked down, the pulmonary hypertension tends to improve. The problem is the immunosuppressant treatments used for SLE can cause complications like we talked about before. And that's all I've got.